Ladies and gentlemen, if you could be seated, please. We'd like to get started on the next section of the program. We'll get started here in about 1 minute, so if everybody could be seated, that would be appreciated. And if all of our panelists for the next session could be ready to go, we will dive back in with thanks to all of our panelists and speakers from the first session. While we get ready, I just wanted to point out to my right and to my left the tweet wall. And it's been a lot of fun to be sitting over here next to said tweet wall for the last portion of the program, because you can see not only are we doing a lot of outbound social media here, but those of you are obviously doing, so you're not just checking your emails. I appreciate that. And a lot of what is being said is getting retweeted, which is great. I would encourage you to keep doing that. You know, I'm going to guess this is a self-selected pretty audience of people who believe in population health, but getting the word out is really important in generating that momentum. So please continue to use social media throughout the day and to get the word out, because it's important, and I think the audience listening to it is invigorated and enforced by it. So that's important stuff. We're going to turn now to the panel on developing a shared vision for healthy cities, looking beyond healthcare to generate shared accountability. And it's my pleasure to introduce the moderator, and she can introduce the rest of the panel, Elizabeth Mitchell, the CEO for the Network for Regional Healthcare Improvement. Elizabeth, thank you so much for being with us, and welcome to all of our panel as well.
Thank you. Thank you very much for having us here. And we have one more panelist who is on her way, but we will get started. There she is. I just have to say how excited and inspired I am from the remarks already this morning. And Sue's vision that she has laid out, I think, really speaks to why we are here. Our collective economic future is essentially at stake. And she not only talked about why a large multinational employer would care about health, but she also turned it into a really optimistic vision, because we can actually create health together. And then Sandro's relentless optimism that we can do this, we own our future, we collectively can make this happen, I think was just really exciting and inspiring. The other thing that I think she said that was so important is we can't wait for government, because we'll be waiting a very long time. I spend about half my time in Washington and a lot of time with my members. I run a network of regional entities who are bringing stakeholders together to solve these types of problems. And when you're in Washington, you hear, I think what could be called dysfunction, and then you go to the communities and they're just getting on with it. They have to fix this, and they are all indebted to each other. They know that it's going to be, the future of their schools, their neighbors. They are all in this together. So there is this incredible sort of pragmatism happening at the community level that I think we can really leverage here to really improve health. So we've talked about that this takes an entire community. No one stakeholder group can do this together. We're all in this together. And we have a vision for where we want to go with the GPS, sort of how we want to get there. But this is the panel that's going to talk about the how. So it all sounds great. We know this is the right direction, but how do we do it? And we are talking about this from multiple perspectives. It's sort of the strange bedfellow strategy. We all need to work together with different partnerships, different relationships. And everybody brings sort of a different perspective to this. They are all seeing different sides of the elephant. They're all approaching problems somewhat differently. But how can we leverage that to have a collective achievement? And I think what's important about the title of this is also generating shared accountability. We all own this. How do we know we're making progress? How do we know that we are actually benefiting everyone that we're seeking to benefit? So We are very pleased to have such an amazing panel. We have George Isham, who's the Senior Advisor for HealthPartners and Senior Fellow at the HealthPartners Institute. And then we have Karen Hein. She's the former president of the William T. Grant Foundation and the Adjunct Professor of Family and Community Medicine at Dartmouth. And she's going to also share her experience working in Vermont for a statewide ACO, which is a really cool idea. And then we have Dariush Mozaffarian, who's the Dean and Jean Meyer Professor of Nutrition and Medicine. And on our prep call, he said, we have to talk about nutrition. You know, if we just talk about healthcare, it's like tinkering with a fire truck to put out the fire. It's just, we're looking in the wrong place. So how do we bring in food systems into this solution? And then we have Bechara Choucair from Kaiser, who is dealing with community health across Medicaid and poor populations and has just a lot of incredible, important experience to bring to this. So we're going to start with having each of our panels say just a little bit about their perspective, their work, and then we're going to dive into the questions. And be prepared, we're going to call on you for questions, so please don't be shy about asking anything of this very esteemed panel. They can handle it. So George, we're going to start with you. Talk about, you're from a healthcare system background. How do you start looking out from inside those walls to really, how do you really drive community health?
Well, thank you, Elizabeth, and appreciate the opportunity to be here in Boston. You know, I've been here 2 days, and you know, we're in flyover country as in terms of the perspective of the East Coast, and I've been steeped in sort of an East Coast kind of perspective for the last couple of days, and appreciate that. Minneapolis, St. Paul, obviously, the middle of the country, and another place where we've been thinking about the same issues that have been facing you. The basic dilemma that we have is the basic challenge that's been around for a long time is life expectancy versus cost. And most recent projections of that I read when I read the literature in Lancet in February, there's projections that our life expectancy, while it'll continue to improve until 2030, may yet fall to the level of Mexico or Croatia, depending upon whether you're a man or a woman. On the cost side, you know, Sue Siegel mentioned in her opening remarks that at the beginning of the Obama administration, General Electric was concerned about healthcare costs rising to 20% as a fraction of gross domestic product. In Health Affairs just last month, there was a projection for national health expenditures to rise to 20% by 2025. So we're back in that game of not only are we not making progress against other advanced countries, but we may actually be declining with respect to our relative position on life expectancy. And again, we still have the expenditures going high. That informs how we as a health system in Minneapolis have been thinking about the issue. So one of the things that we've been thinking about is in terms of cost control, because there's good data, and good data from Massachusetts about the fact that as healthcare costs have increased by 21% over the past 10 years from 2004 to 2014, investments in other social goods and services in Massachusetts has fallen by about 7%. Tremendous, those are things like public health, education, human services, and so forth. It's important. So one of the things that we've done as a health system is to develop a method for measuring total cost of care and then licensing that and giving it away in terms of talking about decreasing costs. When I think about Boston from the middle of the country, I think about Boston as the example, the epicenter of healthcare costs being high. I think about the Commonwealth Fund rankings in terms of cities that I also took a look at. You're ranked 26th. You would be ranked much higher if you had a better cost profile, as I read those rankings. So here, I think in Boston in particular, you have an opportunity to take on that very tough issue. We don't make progress on life expectancy versus resources or a better life for all of our citizens unless we make progress on the tough issues. And there's no tougher issue, I suspect, in Boston than going into the eye of the storm and taking on that issue of costs. Second thing I think you need to think about here in Boston, which we also need to think about in Minneapolis, St. Paul, is the issues around disparity. And I was pleased to see in the your remarks earlier about the ranking of Boston with respect to disparity. So as I look at the maps of education, income, and so forth of the country, you're rich, you're well-educated, you're urban, sophisticated, you love your sports, but you don't distribute that benefit very equitably across the population in this city. So I think of costs being an enabling factor, number one, in terms of freeing up the ability to invest, and I think you ought to be focused on equity. And in urban environments, that's a tough issue, and I'm sure that you and I'm looking right at our previous speaker, she and others know a lot more about how to get at that issue. So then lastly, I'll conclude my opening comment by thinking about how an individual organization, whether you're business or healthcare, ought to think about that. And if you're a healthcare organization, you're in the healthcare business. And across the determinants of health, if you accept the county health ranking sort of distribution in terms of proportional impact on life expectancy and quality of life, you're about 20% is your core business of that impact, healthcare. Health behaviors, tobacco, diet, and so forth, and I'm glad we're going to hear a lot about nutrition down the line, is another 30%. And the other factors, socioeconomic factors, maybe another 50%. So we know a lot about healthcare delivery. We have a lot of control over it, and you ought to hold us accountable for doing as well as we can at a low cost. For health behaviors, we share that with public health. We need to reduce that divide between public health and healthcare delivery. We need to really find ways to cooperate. In terms of the other social determinants, we need to find ways to learn by joining community collaboratives and being part of larger efforts. Secondly, we need to focus our philanthropy. We have philanthropy. We tend to distribute it. Many organizations are not very disciplined. We need to go back and try to focus it so it has impact. And third, we need to think about expanding our remit in terms of healthcare if we can't raise taxes to address some of these issues. But we need to think about expanding our business models so that we address things like poor housing environments and so forth and figure out how to make that a viable part of our business. So I could go through that again for business, because at the roundtable on population health we've done that and tried to look at the rationales for it, but I won't because we don't have time. I will say though that in one analysis I did at the invitation of the people in California and looked at the distribution of regional differences, disparity by socioeconomic groups across the state, and then looked at voting patterns in the last election. There's a very clear alignment, at least in my mind, of voters who voted against mainline Republican and against mainline Democratic parties aligned with poor and disadvantaged areas of the state. And one overriding reason why those of us in healthcare delivery and those of us in business ought to be thinking about that is that I think that's the germ of social instability, and political instability. And we need to be thinking about that with respect to how it affects healthy markets for healthcare, healthy markets for business. So I'll conclude my comments on that.
Thank you, George. So George, on behalf of Health Systems, has invited us to hold them accountable for cost, which is exciting. And Karen, I'd like to hear some about your work. I don't think people know enough about what's happening in Vermont and your sort of collective decision to create a statewide system for health promotion.
So last night, Cliff Leaf charged the group over dinner, the speakers and so forth, to have a vision. So I'd like to take a moment to ask you to imagine what would success look like, not just from this conference, but from all of our efforts. So as you're imagining, what if it were a system that incorporated every person within your area? What if it were a system that had an underlying law that helps you put that system in place? What if this place were ranked #1 for health system in the United States? Do you think there's something like that that exists in 2017? I'm here to suggest that, in fact, Vermont is that place. And although it is a state, it does have a city. But using the definition of shared accountability and shared interest, I think that the state of Vermont is such a place that, in a sense, it's only 627,000 people, but it does have some of the elements of what Boston and other cities have, so that it is a good level to think about intervention and strategy to pull off this vision. So just to hit a couple of highlights, and I hope you'll ask lots and lots of questions. I think, first of all, what Vermont isn't. It is not a state that's going for single payer. That's a misnomer. It was always about having multiple contributors, whether it be Medicaid, Medicare, and commercial insurers. It is not totally a homogeneous state. It has rural and urban. It has progressive and very conservative folks. It has very isolated folks. And it also has income inequality. But what it is a state in which, over the last 20 years, there have been foundation upon foundation stones being built, so that in just the last 4 months, Vermont has taken a huge leap forward towards this vision in the form of an all-payer model agreement with the feds for the next 5 years that calls for such things as a statewide ACO. We have 3 ACOs, they're being merged into one. It calls not only for access to all Vermonters, whether they're snowbirds living in Florida for the winter or they're getting their care in New Hampshire at Dartmouth. If you're a Vermonter, you're part of this system. It calls for targets that 5.3% increase for each of the next 5 years for all of the payers to come in under. It calls for all the MIPS and MACRAs and all of those new alignment with alternate and the newest forms of payment. It's in alignment with that. And most importantly, it's there to accomplish the twin goals of moderating cost and improving health, not healthcare. So just to throw out just a couple of ideas of how could Vermont have gotten to this point, what's the secret sauce, what's happening now, and what could go wrong. In terms of how did this happen, as I said, this has been 20 years of building the foundation for something like this in America. As Len Schaefer says, this is positively un-American. The reason that he said that is because there is a lot of central planning and a lot of alignment. So we've had a governor who campaigned on this and was elected for a couple of terms. We've had a legislature that has totally been involved and backed this. And people who are the coalition of the willing who sit at the table are the insurers, the docs, the Health is a Human Rights campaign folks. So in a sense, we couldn't have gotten to this point if the coalition of the willing hadn't held. So how could that happen? And how could a state pull off something as grandiose as what I've just described? In 2011, the Act 48 was passed that laid the groundwork for this, and it started with 14 principles. Imagine a law that starts with principles and then goes into how we could pull this off. I think the greatest innovation, and perhaps the biggest difference from other states, including Massachusetts, is that there is a body called the Green Mountain Care Board that are regulators, innovators, and evaluators. So as George mentioned, you've done great here in Massachusetts with improving access, but you haven't done so well with cost. So in Vermont, the Green Mountain Care Board is the one group that gets their arms around all the moving parts. So it's not like the balloon where you fiddle with one part and you see the bulge in some other part of the balloon. So let me just take a moment to describe what regulators, evaluators, and innovators mean. So this group of 5 people, of which I was one of the founding members and was served my 3-year term from 2011 to 2014, it does things like sets a target for net patient revenues. And we set 4%. And when the hospitals came in over that, we sent the budgets back and said, you can do better, we know you can. And we gave them a couple of percentage points to increase if they were going to invest in reform that was aligned with the directions that the state was going and so forth. Right now, this morning, I was reading in the local Vermont press that some of the hospitals have come in over budget for the net patient revenues. So you could say, well, that's good. They're making more money. They could have more reserves. Green Mountain Care Board has already told several of them, go back to the drawing board and either return that money to the Vermonters or do something good that promotes health with that surplus. So teeth. In terms of this regulatory authority, not only with hospital budgets, but certificates of need, insurance rate reviews, they have to come and ask if these rates are acceptable. And we do it on two bases, to keep the insurers afloat, but also to be sure that these rates are affordable. There's a couple of examples on the regulatory side. On the evaluation side, Green Mountain Care Board will basically, with the feds, be in charge of the evaluation of this large social experiment called the all-payer model over the next 5 years. In terms of the neutral convener that was just mentioned, the importance of the neutral convener, can you imagine getting all of the hospitals in your area, Boston or in a city or a state together to collude around a system? It wouldn't even be legal, but because the Green Mountain Care Board is a neutral convener, it got around not only the antitrust laws, but allowed actual statewide planning. So I'm just going to mention 4 other ideas that I hope you'll ask me about. One of them is a state budget for health, not healthcare, that we're working on with the Health in All Policies approach to include not only the Agency for Human Services, but now we're moving towards including the Agency for Transportation, Agriculture, Labor, and Education in the statewide budget. I hope you'll ask more about that. Secondly, are the whole effort towards accountable communities for health. We hired the Prevention Institute, did a national survey of them, brought it home to Vermont, and over the last couple of years have now what we call community collaboratives to pull off the 9 core elements of accountable communities for health in 10 of the 14 counties. And lastly is to keep your eye on this all-payer model, because again, it was signed before the election, and the only way out is if either party, the feds or Vermont, give 180-day notice. But I think the reason we've gotten this far has been because of the lack of understanding or attention by the press, by Big Pharma, you name it. Nobody knows what's going on in Vermont. So you're part of the secret now. And that's important because, again, at least understand that what we're doing is talking about a single pot from which comes a single system. And that's really a great leap forward. So I look forward to many of your questions and to mixing it up with our panel, because I think we do have some really good strategic approaches that are on the ground that are happening now.
Thank you, Karen. And that was a lot of hows, or at least we're starting on some hows to how to get at this. But a theme that I'm going to come back to after we hear from everyone is the relationship piece, because this is about new and different relationships, and there is going to be some inevitable tension. I've said to Alan, if everyone is being polite, you're really not talking about the real issues. So going to a hospital and saying, actually, you got to revisit that budget. You've got to do better. I think how we relate to each other to get there is going to be an important theme. We're going to go to Dariush next, and tell us about sort of, you've talked about sort of the fire truck analogy, and we're looking at the wrong area, and I think it's safe to say Rome is burning. What should we be thinking about in terms of really getting at the fundamentals of health?
So first, thank you to Sandra and BU and to Sue and Robert from GE for hosting this event and letting me participate. Sandra and I were talking. We just found out that our schools are 1 mile away. We're 1 mile north here, the Friedman School of Nutrition Science Policy at Tufts, and we've, like BU, been really thinking about communities and how to have healthier communities. One of our signature projects was Shape Up Somerville, which was focusing on childhood obesity, now 15 years old. And Shape Up Somerville was the inspiration for Michelle Obama's Let's Move program. So when she launched Let's Move, the mayor of Somerville was there at her side, showing that your community can come together and tackle childhood obesity. And now that program is now national in Child Obesity 180, which is reaching 9 million children, on goal to reach 20 million. So we really think about these issues carefully. I think that as a cardiologist and as somebody with also a PhD in public health and epidemiology, I recognize the value of the health system, and if family members get sick and others get sick, we need the health system. But truly the elephant not in the room is the food system, and quantitatively, we've shown this and published this, and the Global Burden of Diseases has published this. Poor nutrition has now surpassed every other modifiable risk factor as the #1 cause of death and disability in the world and in the United States. That includes tobacco smoking, physical inactivity, drug addiction, violence, obesity, every other, and of course obesity is also due to nutrition, of course. So literally this is the #1 cause of poor health in the country, and it's almost totally ignored by the health system. And so that single fact explains the situation that we're in. And you think that housing is complicated or education is complicated. The food system is actually even more complicated, from agriculture, global commodity trade, to Cargill and Bunge and other companies putting the food around the world, to retailers, right? It's not just about, people think about food industry, but think about retailers and all the restaurants and cafes and cafeterias that are built into the system. And then other places, government work sites, schools where food is served, feeding programs, and then consumers and their confusion, and cultural issues and social issues. So the food system is incredibly complicated. The really good news, and I guess the second complexity, actually, just to before I go to the good news, is that as opposed to tobacco or physical inactivity or opioid abuse, where we actually at least know what we want to do. We can say we don't want people to smoke, we want people to move more, we don't want people to abuse opioids. People are really confused about what does healthy food actually even look like. What should I be having? Gluten-free? Should I be having low carb, high carb, paleo, coconut oil, GMO, organic, local? I mean, I could go on and on. And so even just the target is a matter of confusion. So I think that the great news, the wonderful news, is having been in this research for about 20 years, we've just in the last decade, the nutrition science and the policy science has advanced sufficiently where we don't know everything, but we have really clear ideas of where we should go on the nutrition science side and where we should go on the programmatic and policy side to make a difference. And I'll talk about the latter. I won't talk about the former, although maybe in the break we can talk about that. But on the programmatic and policy side, I think there's a suite of menu options that different organizations, different cities, different places have all tried and have all been shown to be highly effective, and we need to put all of those into the system. And so that includes financial incentives. And so whether it's work sites, whether it's Medicare, whether it's Medicaid, whether it's private insurance, whether it's other employers, just like we have worksite wellness programs that reward people for being in gyms, or increasingly some insurance programs that reward people for smoking cessation, we need to give people financial rewards for better eating. And there's programs that work. We're partnering with John Hancock Life Insurance. They have a great product called Vitality, which they pay $600 back per person per year for healthier eating. And John Hancock's done the math, and they have 1.8 million life insurance customers, paying them $600 per person per year. They get money back in their pocket. John Hancock does, and because they'll live longer and be healthier. So reward systems, financial incentive systems, through, again, GE should absolutely do this for their entire workforce, is an obvious natural thing to do. And again, people are starting to get this about physical activity. Nutrition is next. There needs to be quality standards for certain things, in particular additives that are city, state, and federal quality standards. Trans fat has been mentioned as an additive. Sodium and added sugars are the other two major additives. So quality standards is sort of a minimum thing that we can do. There needs to be organizational innovations and systems changes in schools and in worksite wellness and in government work sites beyond just the financial incentives, thinking about the food environment, what you serve, what standards you have, choice architecture, things like that. And then there needs to be health systems innovations related to nutrition. So again, the #1 cause of poor health is not in the electronic health record. So Kaiser Permanente has been leading the country in thinking about lifestyle. They've added an exercise vital sign or physical activity vital sign to the electronic health record that every single person now gets. They need to take that to the next step with a nutrition vital sign. And smoking is so obvious that we ask about it. You ask about it on every history and physical. Every medical student learns to ask about smoking. They don't know how to ask about or record nutrition. And then the healthcare system needs to have rewards built into it to encourage better nutrition. Senator Portman in Ohio in 2013 proposed a better health rewards bill for Medicare to pay back seniors about $200 a year to do certain health behaviors, and that included mostly screening and physical activities and so forth. Nutrition should be right up there, right? If they do good things for nutrition, Medicare recipients should get dollars back in their pocket, and again, there's ways to do this, like our John Hancock partnership shows. So we need to put nutrition into the healthcare system, and we need to change medical training, right, to have nutrition. And the simplest way to do that overnight is just change the boards, right? Change the U.S. medical licensing exam, change the internal medicine licensing board, change the cardiology boards, change endocrinology boards, put 5-10% questions on nutrition and lifestyle. You'll change medical education in every school, within a year, right? Because they teach to those exams. And the last thing I'll mention, that as the last thing that we really need to do, is to work with industry. Food industry, fortunately, as opposed to tobacco, can be part of the solution. So it's not a fight to the death, right? Tobacco is a fight to the death, and there's only 5 or 6 companies, and we don't want their product, right? But with food, there's incredible diversity and heterogeneity within the food system, within companies, across companies, and with the exception of some products like sugar-sweetened beverages, which really have no value, and you have to just basically we have to get rid of sugar-sweetened beverages. Almost every other food product, if we shift it, if we change it, if the companies can sell healthier food and make a profit, they're happy, we're happy. And so I think a better analogy than tobacco, I think of as cars. So if we think about what we've done with the automotive industry for car safety over the last 80, 90 years, and the reduction in deaths per mile driven by cars was named by CDC as one of the top 5 public health successes of the 20th century, a 90% decline in deaths per mile driven. How did we do that, right? We did it by addressing the driver a little bit, right? I don't think drivers today are that much better than drivers in 1930. Probably were the same. We assessed the driver a little bit, licensing standards, texting rules, and so forth. Really, we addressed the car. We dramatically changed the car, safety standards, crash standards, shatterproof glass, airbags, and we could go on and on. We changed the environment, roads, speed limits, rumble strips, we could go on, and we changed the culture, especially around drunk driving with MAD, designated driver campaign. So that's the roadmap for the food system. We need to address the consumer a little bit, but we need to address the product. We need to address the environment, which is our cafeterias and our restaurants and our grocery stores. We need to address the culture so that movie stars and pop stars aren't pitching unhealthy food. Well-educated people aren't bringing gummy bears and pretzels to soccer games. I have three young kids, and McDonald's isn't the place you take your kids for the fun treat, unless McDonald's, of course, can sell healthier food, and they'd be happy to do so if they could make a profit doing so. So I think that's the recipe, is we need to do those things and work with industry. And I think it's got to be carrots and sticks. It can't just be carrots. So there has to be some real problems for the food industry if they don't comply. And we do that for housing, we do that for computers, we do that for toys. We have safety standards for almost everything in our entire universe except food. And so I think that has to be done.
Thank you. And now we're going to turn to Bechara. You're from a very progressive, vertically integrated health system. Kaiser says we'll keep you healthy from cradle to grave. So what can you tell us that we should be doing based on your work? What your lessons from working at the community level?
Well, thank you so much for inviting me. It's great to be with the panel. It's great to be with everybody here. Before I give my remarks, I just wanted to, it was great listening into Monica this morning. And once you're a health commissioner, you're always a health commissioner. So I served for 5 years as the health commissioner for the city of Chicago. And it was great listening into Monica bragging about Boston getting the gold medal from City Health for the 9 policies that were identified. And not that I want to brag about Chicago, but Chicago also got the gold medal from City Health. So thank you, Monica, for all the work that you're doing on behalf of Bostonians. So just briefly, I want to talk a little bit about some of my work, or how my views on how we improve city health have evolved over the last few years, particularly now during my tenure at Kaiser Permanente. And for the folks who are not familiar with Kaiser Permanente, we're one of the largest integrated healthcare delivery systems. We provide care to 11.7 million members across 8 states and the city of Washington, D.C. And the way we look at our role, that we are about providing affordable health care for those 11.7 million members, and we want to do everything we can to improve their health outcomes, but we're also about improving the health and well-being of the communities where we're in, and that's 65 million people. So as by the facts of our mission, we are about improving health and well-beings of communities, and that's where the efforts around focusing on what would it take to improving health and well-being of communities is integral to what we do as an organization. So if you think about our 200,000 employees across the system and our 22,000 physicians who are part of the system, this is core to what we think about on a regular basis. And from my experience as a family physician, seeing patients in healthcare for the homeless programs within federally qualified health centers, or running the Health City Department for the city of Chicago, where 2.7 million lives, or during my tenure at Trinity Health, which is another healthcare system, I think I found that there are 3 areas of focus that are so critical if we want to really be transformative in improving health and well-being of communities. The first area is making sure that people living in poverty have access to clinical and social services. So I'll come back and talk a little bit about that. The second area is really how do we focus on policy systems and environments, and how do you create a movement to really do place-based work in communities that you're in as equally as important, if not more important. And the third area is how do we integrate and weave innovation to be part of our work as a community or as a society. So those are, from my perspective, the 3 areas that are critical if we want to be serious about transforming health and well-being of communities. So just briefly on each one of those, and I'll be happy to answer questions later, but when you think about access to care for people living in poverty, there's one population I'd like to highlight today, and those are individuals across this country who are duly enrolled in Medicaid and Medicare. I don't know how many of you are familiar with dual eligible patients. These are seniors living in poverty or people with disability living in poverty. And you look across the country, and we have probably around 10 million of these folks. And when you look at how much money we spend just to provide them with healthcare services, that's 2% of our GDP. That's not just 2% of our healthcare dollars. 2% of our GDP as a country is spent to provide healthcare services for dual eligible patients. So as we think about how do we really take a good look at healthcare costs, maybe that would be a great populations to focus on. And then I want to also highlight the fact that a lot of folks who are living in poverty, they really look at the healthcare system for more than just clinical services. For this population and many other populations, it's really important to think about how do we provide the wraparound services. So it's not just about the prescription for glucotrol or the prescription for Zyprexa. It's really about transportation, it's about food access, it's about housing. So how do we get our healthcare system and our social services systems to connect in a more integrated way, in a more effective way, I think is going to be critical for any city that's focused on improving the health and well-being of its community. So that's one area. I'll be happy to talk a little bit more about that. At Kaiser Permanente, we have almost 1 million Medicaid members across our system. So for those folks and for others, ensuring that we have good, solid connections with our community partners in the social services sector is a key part of that strategy. The second piece is really around policy systems and environments, and I think we've heard a lot from Monica, from Sue, and other folks on the panel, and I'm sure Karen will chat about that a little bit more. You know, we can't expect to transform health of communities if we're not going to be really serious about those policy systems and environments. And for us to be able to do that, I think a key element of that is how do we engage community residents to really be activists in our communities. You know, I look back at during my tenure in Chicago, you know, the Chicago Public Schools serves 75 million meals every year. And you know the group that really was the most influential in transforming that policy so that the food that's served as healthier food is a group of parents who really were very active, who were community organizers, who went to Board of Ed meetings, went to parent conferences, spoke out, were very active, very vocal, and really were drivers behind changing that policy. So as part of that effort around policy systems and environmental changes, it's really important to figure out how do we continue to support and elevate the voice and amplify the voice of community organizers or residents who are interested in that. But also institutions have a significant role to play as anchor institutions within communities to make a difference. So at Kaiser Permanente, we invest every year almost $2.5 billion in resources to go back to improving the health and well-being of our communities. And then we started asking ourselves, how can we leverage the other $65.5 billion that we invest every year so that we can make a difference in our communities? You know, how do we look at our procurement? We purchase billions of dollars worth of stuff every year. How do we make sure that we're procuring locally? How do we make sure when we're hiring folks, we're looking at local residents for our hires? How do we make sure when we're investing our portfolio, we're investing in things that would lead to improving health and well-being of communities? How do we make sure that we're purchasing from minority-owned businesses and women-owned businesses? So how do we look at our own portfolio, our own regular day-to-day business, and making sure that we're leveraging that to improving our health and well-being of our communities? That's what we call total health, and that's what part of where we're committed to making a difference. And then we're also interested in place-based interventions, and how do we bring different sectors together to really try to advance that agenda around changing the policy, the systems, and the environments. And at Kaiser Permanente, we're in 52 communities where we're really bringing different stakeholders together to try to figure out what are these policies that we'd want to change. How can we accelerate that change? And we've invested over almost $60 million to support these efforts in those 52 communities. So lots of opportunities and leveraging policy systems and environmental changes to transform communities. And then the last key element, I think, that's critical to transforming health and well-being of communities is really around innovations. And for us as a system, we have 70+ year history of being leaders in community health and the way community health is delivered in our country. And if we want to continue to be leaders in the way community health is delivered in this country, we really need to be looking at social innovation, but also at emerging promising technologies. And I ask myself every day when I hear my colleagues on the clinical side thinking about artificial intelligence, thinking about virtual reality, augmented reality, thinking about predictive modeling, thinking about blockchain, thinking about robots, 3D printing. While we're trying to figure out where these promising technologies have a place on the clinical side, there's absolutely a role for us to think about what would it look like if we leverage those technologies into improving health and well-being of communities. And we need to try a lot, pilot a lot, fail a lot, but I know that there's going to be an opportunity there. And during my tenure at the health department in Chicago, we really tried to leverage a lot of how do we use predictive modeling to doing restaurant inspections in the city of Chicago? How do we actively listen to Twitter to try to figure out who's complaining about food poisoning in the city so that we can interact with that resident and really encourage that person to answer 4 or 5 questions so we can send our inspectors, do an inspection, and then post the result of the inspection online? And what we found out when we do that, 87% of people who tweet about food poisoning would respond to a tweet from the health department back at them and saying, hey, if you answer those questions, we're going to send an inspector. So I think leveraging technology has a lot of promising opportunities in improving health and well-being of our community. So I'm going to stop here and look forward to the questions from the audience.
And I am going to open it up, but I'm going to take the prerogative of asking the first question, and I'm going to ask you to be very brief in your answers. But we've heard so many ideas from multi-payer alignment and central planning to training community activists, and all of this sounds so good, so obvious that we should be doing this. Let's get real for a minute and say, why isn't it happening? And there's probably a long list of reasons, but I want you to pick one barrier that you've encountered in your work and one solution. And you've got to limit it to one. So George and I spent about 1.5 years together on an IOM committee and to define measures of health. And it wasn't that hard to come up with the measures themselves. We completely fell apart when it came down to how do you implement this. We really struggled with that. So name a barrier and name a solution. George, you get to go first.
Well, I think that when you think about these objectives in the abstract for a large community, and a large population, it's difficult to transition to specific leaders and accountabilities around implementation. So let's again take Boston. Let's take our recommendation around cost. It would not be hard in Boston to identify the institutions that are high cost for healthcare delivery, go to the web and find out the names of the board of trustees and directors, and then have a conversation. The hard part would be having a conversation with them about giving up the yield that comes from maximizing your top line income if you're a finance person. In terms, that's the real conversation, because they need not only to do that in terms of making sure we don't further eat the seed corn for the rest of the social interventions that we need, but you can identify people that are accountable. You could have the conversation, but it's awfully difficult, and you need the personal relationships. You need them engaged in socializing to that problem. In Minneapolis-St. Paul, we did that around high-tech imaging, where we have a collaborative that raised the issue of the inappropriate use, according to the standards by the American College of Radiology, for high-tech imaging. And we had, in a small room, the leaders of those health systems hash that out, where they could say, I'm afraid to give up that revenue that's associated with it. But there was enough, in a sense, publicity in terms of the number of people in the room for them not to say, I'm going to do that by advocating inappropriate care. And so we did agree as a state to do that, implement the technology developed here at the Mass General, statewide, through the collaborative, and we saw health systems give up that revenue. So, and a little bit of a story, tough issue, you have to come at it, you have to have relationships, but identifying it first and then going at it.
I think you could marry that with Bechara's training community activist approach, and you'll really get something going. All right, Karen, one barrier, one solution.
Biggest barrier, I would say, is trust, especially now, especially in America. So who do you trust, and how do you get a trusting relationship to the point where you can do this? So first of all, I would say that for people to feel that they have a seat at the table is really important. So when you're putting together whatever community-based coalition, do you have the people who have felt that they didn't have a voice before that? An example would be in Vermont for this whole Accountable Communities for Health movement. 14 counties, we gave support, infrastructure support, to 10 communities to actually, their counties, to actually pull together their Accountable Community for Health group. And 10 of them did it, and 10 of them did it in 10 different ways. So we gave them the 9 core elements of an Accountable Community for Health: transparency and data and governance and a way to finance these things. But then we let them figure out in their community how to pull it off. The role of the hospital, as one example, in northwestern Vermont hospital system, they helped to launch something called Rise Vermont, which is community-based health interventions. So it's possible for the hospitals to play a role, but such a different role than they have, to create a different kind of trust, with the community focus being the real locus of control, action, and intervention.
Great. Thank you. Okay, Dariush.
Yeah, so thank you. So for addressing the food system, I think the barrier has been confusion. Confusion about what to focus on, confusion that diet is an issue of free choice and education rather than a systems problem that can be addressed through systems changes, and sort of confusion about what to do. And the reason that there's been confusion is that it's a remarkably young science, and I would say that the science of diet and chronic diseases, as opposed to single nutrient deficiency diseases, is only about 30 years old, actually. So it's a remarkably young science. And so we've had our growing pains in nutrition science. And so the low-fat craze, being one example of that. Again, the focus on individual willpower as the solution being another example of that. But I think what's the solution is now that the science has advanced, as I mentioned, dramatically. And so we need to get that information out to businesses, to policymakers, to people who can influence these systems, and it's really win-win. Money is saved, people eat better and eat healthier, and it actually costs less. So there are almost no interventions within the health system that are truly cost savings. Vaccines might be the only example. So in the health system, you're fighting over making things more cost effective, but there's almost nothing that's cost savings, where you spend $1 and you get more back in your pocket. Nutrition and nutrition interventions, and there's many studies on this, are if done well and done scientifically based, are actually cost savings. And then I'll just really mention that the confusion is why we're partnering with John Hancock, because they realized as soon as they launched their program that people were like, well, what should I eat? What should I buy? What's a healthy food? And so having sort of a credible partner to give that trusted science, I think, is really crucial.
Thank you.
Just briefly, I mean, I think improving health and well-being of communities is complex, it's hard, and it takes a long, long time. That's, to me, is probably the biggest barrier, and the only way we can address that barrier is by creating a movement. And when you create a movement and learn from others who create movements really, really well, that's how you create momentum and you keep the momentum going.
That's great. All right, who wants to join the movement and ask a question? Any questions? There's been a lot of ground covered up here. Yeah, right here.
For Dr. Mozaffarian, I just had a question on whether you find culture and cultural diversity as a barrier maybe to influencing diet change, and if so, sort of how you would address that. And then as a second question, what does a typical dinner look like in your household? That's what's on it.
The first question that people didn't hear was is cultural diversity a challenge? And I think it is for two reasons. The obvious reason is that different cultures eat different foods, but there is a common set of foods that are healthy that you can make culturally appropriate. We talked about this at dinner last night. It's foods that give rise to life. So nuts, beans, whole grains, fruits, seeds, foods that sprout and give rise to life, and you can find those in every culture. The real barrier to the real cultural problem with all of this is that food is so personal that everybody feels like they're an expert. And so if I go to a dinner and I say that what I do, everyone wants to talk about the topic for at least a little while, and everybody has their own answer. And if I were a physicist, talking about how to get the spaceship to Mars, or if I were a breast cancer doctor talking about chemotherapy, everybody wouldn't give me their opinion of what I should be doing. But in nutrition, everybody thinks they're an expert. And so I think that's really one of the challenges we have, is cutting through this kind of a mess and bringing out really the true science. And your second question, remind me again. Oh, what do I eat at dinner? What do I eat at dinner? So our dinners, tend to be things that can be made quickly. We have 3 young kids. My kids are 4, 6, and 8, and my wife and I both work. My wife works at Harvard School of Public Health and does childhood obesity work. And so we are busy, and our kids are hungry. And so things that are simple and can be assembled, we tend to assemble, not to cook. And we tend to eat lots and lots of fruits and vegetables. Fruits are wonderful. The kids always have fruit as the snack while they're hungry, while we're getting dinner ready. Put fruit out, they'll eat it. Put carrots out, put hummus out, they'll eat it. Put green beans out, they'll eat it. So lots of fruits and vegetables, fish. And then we think of starches as the side. So starches are always the side. You have chicken or fish or other kind of healthy foods. Lots of dairy, lots of cheese. Cheese is probably actually pretty good for you. Fermentation, we can talk about that later. And so I think it's again focusing on the good, trying to get the good in the diet, and then minimizing starch and sugar.
Next question. Yeah.
Sorry. Oh, sorry about, whoa, too close. Microphone, how you doing? James Puccioni from the Mass Healthy Aging Collaborative, and we work from sort of a World Health Organization playbook with 8 domains of livable, a livable community or a livable city. One thing that's noticeably absent, and I apologize to go back to the professor on this, but nutrition's not anywhere near the 8 domains. And I was wondering if you had any examples of community-based solutions or municipal kind of led policies that have had an impact on local health, because certainly access to healthy foods for older adults is a huge issue, and we talked about dual eligibles on the panel as well, so I'm sure that's an issue, but just the question out there if you have any examples that have made an impact.
Yeah, and in the CDC High Five, nutrition wasn't on that list. In the SDGs, the UN goals, the Millennium Development Goals, SDGs hunger is on there, but good nutrition, good food for chronic disease is not on there. So it's again, it's the elephant not in the room in all of these discussions. And so, yeah, I think that there are actually national examples and city examples, and so I think WIC is a great example. You know, the Women's Infant and Children Feeding Program has very good health standards, and the only group in the United States where obesity has gone down is under 5, and I think WIC, which feeds one in two kids, 1 in 2 babies in the United States are on WIC, has had a major role in that. SNAP, the program that feeds 1 in 6 Americans, the food stamps program does not have any nutritional guidelines, and the number 1 item purchased in that is sugar sweetened beverages, about 60 million servings per day purchased by taxpayer dollars for the exactly your population of 10 million people and many others. So that needs to be changed. But so I think there are many individual examples. The Shape Up Somerville example, it was focused on kids 3rd to 5th grade, and was very focused but had success. New York and the trans fat example has had success. Kuopio in Finland had the highest rates of heart disease in almost any city in Europe, and over about 10 years focusing on reducing sodium, improving healthy fats, increasing berry production, reducing smoking, increasing physical activity. Over about 10 years they went from one of the worst to one of the best. So Kuopio is a great example. So I think there are lots of really good examples, and they all use these different approaches that I mentioned before, working with systems changes rather than relying on the individual person to make the healthier choice.
We have time for one last question, and in the back, I saw your hand up earlier. Thank you.
Hi, thanks so much. My name is Mackenzie Marcoville, and I work with the Greater Boston Food Bank. And this is essentially the apex of what we're doing on a daily basis in trying to understand our role in using food and food access and access to federal programs to create healthier communities, particularly for especially vulnerable populations, low-income seniors. We do work with WIC. And part of this work is actually collaborating with community health centers to do hunger screening and eventually get some sort of hunger vital sign into electronic medical records. There are a lot of folks that are doing similar pieces of this. And my question really is, we've talked a lot about convening different organizations because I think that there are so many actors in this right now. I wonder kind of for the panel if you have suggestions of the best ways to do those sorts of convenings that aren't necessarily like the one-off conversations.
That's a great question. You want to just start and come down really quickly?
Sure. So this is such an important topic, and I know for many of our Kaiser Permanente regions, there's a focus on food insecurity. Colorado is probably doing the best work there, where we're screening people for food insecurity within our health system, and we've created relationships with the food bank there, with Hunger Colorado's coalitions, to really be able to address the needs of those members. So I think from a practical, pragmatic perspective, it's important that we're screening people, connecting people to services, and we're creating an infrastructure that would support the relationship and that meeting the needs of our members. But also we're part of coalitions and part of part of efforts within the community to address that need. For me, I think it really boils down to, are we screening people, are we connecting them to care?
Okay. Really.
Yeah, so very briefly, I'll just echo Sue and Sandro and Monica's comments that business really can be the convener, because academics and government doesn't have the resources to keep these things going. Monica was very optimistic talking about Public Health 3.0. I think we're in Public Health Beta. She has $160 million a budget, I think I heard correctly. She should have a $16 million budget. I mean, that's a tiny, tiny fraction of healthcare spending in Boston, right? It's nothing really for the things we need to do. So I think business has the expertise, resources, and the stature, and it's healthcare is a crisis for competitiveness of U.S. business, and so I think business is a great way to keep the conversation going.
I would suggest 3 elements. The first, at different levels. On the statewide level, pulling off something as innovative as a budget for health, which would be the first in the nation. David Kindig said can't be done. We got a grant from RWJ to allow us to pursue an expanded expenditure analysis. But the way it happened was to have a health and all policies task force that engaged every agency head in this effort. The second, so that's at pretty high level, the state level. In terms of, again, the Green Mountain Care Board, because its job is to innovate, evaluate, and regulate, many of the sort of squishy areas that don't get covered in terms of convening and permitting and encouraging are done through that mechanism. At the community level, again, going back to the idea of accountable communities for health, was to give them some support to be able to have some infrastructure to convene their own meetings, let them set their own priorities, let them have a sort of guidepost with these 9 core elements of accountable communities for health, but support their ability to do what makes sense in their community or county.
Great. George.
So our approach would be one where we take that relationship that I talked about with respect to the social determinants of health and then try to operationalize that through priorities. So one of our priorities at HealthPartners in Minneapolis is education, and so we have direct programming in many of the schools that are in the footprint of our care delivery systems across the Twin Cities that are working with children in terms of nutrition and activity. We capture that in a measure of well-being up to date, which includes tobacco, nutrition, activity, and alcohol abuse for adults, and then there's a modification for children. And then we incorporate that, measure that for our delivery systems, and actually create incentives about that. I think you asked for that, a version of that. And it's not as robust a version on nutrition, but it starts with fruits and vegetables. And then the partnerships with the food shelves across the Twin Cities and addressing hunger. Again, Bechara mentioned that. We also are very active in terms of addressing that issue of hunger and so forth. So there are a lot of ways that healthcare systems, delivery systems, as well as healthcare insurers, if they have their populations, can address one, finding the need, and then figuring out the different partners where they need to partner and figure out how to solve some of these social issues and problems that relate directly to the health care outcomes that you're concerned about, as well as the larger social outcomes.
And I'm going to throw in a pitch. I'm admittedly biased, but in over 35 regions around the country, there are these entities called Regional Health Improvement Collaboratives that are bringing all the stakeholders together, employers, providers, patients, state governments, and many of them are making significant headway in tackling these things collectively. But those don't work. None of these work, I think, without leadership. And that's one of the things that we didn't hear explicitly up here. But I think it goes without saying, and you're seeing this leadership demonstrated by this panel. Someone has to just step up and say, we're going to own this problem, whether it's a business, whether it's a provider group, whether it's a community organization. But that leadership and that the collaborative leadership skills to listen, to build trust, and to really honor everybody's interests at the table, to really get them to put community interest over organizational self-interest. So those leadership skills are essential, and I think you have incredible examples up here on the stage, and I want to thank our panel for all of the work that you're doing on our collective behalf and for sharing that with us today. So thank you very much.
Thank you very much. It was a great panel. What I would like to do now, we are just slightly off schedule, not bad, but because we don't need to reset the stage, I'd like to ask if you need to go to take a personal break, feel free, but if I'd like to work through the break to keep us on schedule for the afternoon, the lunch has already been set out in the back. So after our next panel, we'll have a lovely lunch. You'll see that it's a series of box lunches. You'll see that they're labeled as to what is inside them. I kid you not, the one on the right must have been brought by the nice people at Tufts because it says the greeny and nutty entree. I don't know what that is. No doubt a veritable wonderland of legumes inside that box awaits you, but we'll see which one the good Dean goes for first. I'm guessing he picks up the short rib grilled cheese, but there you go. So why don't we go ahead, Susan, and bring the rest of the next panel up, and let's, what? We need 3 minutes to change mics. Sorry about that. There is a shortage of microphones, so we'll do that. So we'll take a very, very short break. just while we do the mic change. If you can stay seated in here, that's great. And we'll be ready to go in just a couple of minutes and get everybody on for the next panel.